So we'll begin with the session. A very good morning, good afternoon, or good evening to you, depending from which part of the globe you are connecting with us. It's my pleasure to welcome you all to the fourth academic webinar of TUGS Endoscopy. I am Dr. Bhavneet Bhalla. I am a consultant surgeon and the chief coordinator for TUGS Endoscopy. Today, I, along with my co-host, Dr. Mosania, who is also a member of the TUGS Endoscopy Council, will be your host for this session. Now, as you are all well aware, endoscopy has now become an integral part of a surgeon's practice. And we are actually heading towards an era of hybrid endo-lab procedures. Now, the scope of endoscopy in the management of surgical diseases is expanding rapidly. Now, hence, it's the need of the hour that all surgeons should learn and do endoscopic procedures necessary in the management of these surgical diseases. Now, keeping this in mind, today we are going to discuss about two of the most commonly performed therapeutic endoscopic procedures, namely the removal of foreign bodies and secondly, the management of GI bleed. We have invited a great panel of speakers and experts to discuss various ways and techniques of these procedures, to deliberate upon that and to answer your queries. So we are going to have two talks today, which will be followed by a Q&A session and panel discussion. Now I request all of you to type your questions in the chat box, and I and my co-host will put them forward to the speakers and panelists on your behalf. So to begin the session today, I'll introduce the panelists first, and then we'll have our first talk. Now, today we are having three panelists. I would like to introduce Dr. Arvind Kumar Khurana, who is a senior consultant gastroenterologist and the head of gastroenterology department at Fortis Hospital, Gurgaon. He has a vast experience of over 30 years in the field of gastroenterology. Now, Dr. Khurana has been awarded the fellowship by the Royal College of Surgeons in 2006. His area of research and expertise is in ERCP, stone removals, metallic stenting, pediatric and neonatal endoscopy, and PTBD. I would like to mention that Dr. Khurana has been one of my earliest teachers when I started learning my GI endoscopy. So it's a pleasure to have you here. Welcome, sir. Now, our next panelist is Dr. Sunil Kumar Elur. He is a laparoscopic GI, bariatric, and colorectal surgeon from Bangalore, India, with over 2 decades of experience in medical practice. So he has keen interest in GI endoscopic teaching as well as training. Now, after this introduction of the panelists, it's time for our first talk. Our first speaker for this session is Dr. Xavier Dray, who is a professor of medicine and head of Center for Digestive Endoscopy at Sorbonne University Hospital Saint-Antoine, Paris. His current research focuses on technical innovations for gastrointestinal endoscopy, with a special interest in artificial intelligence and embedded systems relevant to GI endoscopy. Now, he has built a significant collaboration with several teams and working groups in the field of capsule endoscopy, including a partnership with the L1P6 laboratory at Sorbonne University, Paris. Due to some unavoidable circumstances, Dr. Dray could not join us for this live session, but he has been kind enough to record and share his talk with us. I would now request Dr. Patha to start Dr. Ray's talk. Dr. Patha, over to you.
Good morning, good afternoon. My name is Xavier Dray. I'm head of the Center for Digestive Endoscopy at Sorbonne University, Saint-Antoine Hospital in Paris, France, and I am very pleased to present this lecture entitled Foreign Bodies of the Digestive Tract, Do's and Don'ts. I have some conflicts of interest. As an introduction, I would like to emphasize that this lecture is based on the following paper published in 2021 in Frontline Gastroenterology, and this paper was based on a high amount of clinical experience with limited level of evidence. There will be more do's than don'ts during this lecture. Why us addressing this question? Because we at Saint Antoine Hospital, we lead a mobile on-call endoscopy team that covers a 5 million inhabitants area at nights and weekends in the Greater Paris area. Do make varied equipment available to face varied foreign bodies ingestions. Aside to a standard flexible gastroscope, you may consider to use a nasogastroscope in children or to pass a stenosis, a colonoscope or a therapeutic gastroscope with a 3.2 or 3.8 single operating channel, a double channel endoscope, allowing the combined use of devices. You may also consider to use a rigid pharyngoscope that has a larger working channel and a stronger grasp. Numerous retrieval devices are available. The chosen device will depend on the size and shape of the foreign body, but also on the length and operating channel width of the endoscope and the endoscopist's preference and habits. Foreign body retrieval forceps, such as rat tooth, alligator tooth, or shark tooth forceps, are most often used. Retrieval forceps with 2 to 5 prongs can be useful to retrieve soft objects, for footballers example, but they do not provide a secure enough grip for harder or heavier foreign bodies. Baskets with 3, 4, or 6 wires, such as the Dormia basket, can be used for round foreign bodies. Standard polypectomy snares and retrieval nets are also used and widely available. Balloons can be used for removal of hollow foreign bodies. In addition, special equipment, overtubes, hoods, transparent distal caps must be available to protect the airways and the esophagus mucosa when removing sharp or pointed foreign bodies. Another do. Do secure data collection when you are on call. Decision-making process is mainly based on information received on the phone, on medical knowledge and clinical experience, and on available resources. As the degree of confidence of any information given on call may vary, it is of tremendous importance to note and to archive with a precise timing what has been told by, proposed to, and eventually decided with multiple caregivers, nurses, emergency physicians, intensive care physicians, surgeons, radiologists, and so on. Do anticipate general anesthesia with endotracheal intubation for airway protection for upper GI foreign body extraction. In most non-urgent cases, upper GI endoscopy can be managed without conscious sedation or with conscious sedation without airway protection. Patients must be lying on their left side with the head slightly lowered to reduce inhalation risk. However, in the emergency setting, general anesthesia with endotracheal intubation for airway protection is appropriate in most cases and must therefore be anticipated on call. It is an ESGE recommendation that any patient with hematesis, agitation, or encephalopathy should have general anesthesia with endotracheal intubation prior to endoscopy for upper GI bleeding. It should also be strongly considered for foreign body extraction, particularly for young children, in case of poor patient tolerance, and/or when multiple sharp or pointed foreign bodies must be extracted. In any patient with a full stomach, recent meal, active bleeding, foreign body, endotracheal intubation with a rapid sequence induction technique is recommended. Do not plan lower GI endoscopy for removal of a rectal foreign body. Look at this plain radio. What do you think is this foreign body? The vast majority of rectal foreign bodies should be manually retrieved by surgeons under direct vision through the anal route or during laparotomy in case of a complication, impaction of perforation. Lower endoscopy with a little help to remove those large foreign bodies may play a role together with CT scan when a complication is suspected after
Hello.
transanal retrieval of the foreign body. Of note, any attempt to remove rectal drug packs is contraindicated. This is hard to believe, and it is also sometimes hard to pass. Do not go for endoscopy in these cases. Do immediately proceed to endoscopic removal of sharp or pointed objects, even when it is within a food bolus impaction. Any pointed or sharp foreign body should be extracted without delay. In this setting, a recent meal is not a contraindication to urgent endoscopic removal. Again, a general anesthesia performed with a rapid sequence induction technique and with endotracheal intubation must be anticipated in such patients with a full stomach to reduce the risk of pulmonary inhalation. Radiological workup is not mandatory and should not delay urgent endoscopic removal of a pointed or sharp foreign body. Do not delay endoscopic removal of food bolus impaction over 12 to 24 hours. Most food impactions occur in the esophagus. Meat is responsible for most cases in the Western world. Hypersialurea is a sign of complete esophageal obstruction that requires urgent endoscopic removal. In any other case, food impactions should be endoscopically removed within 12 to 24 hours because of the risk of perforation. Radiographs are of little help to confirm the presence and to determine the location of non-bony radiotransparent food bolus in the esophagus. In the absence of any clinical sign of complications, radiological evaluation has a low diagnostic yield and a low impact on therapeutic strategy. It is not necessary in most cases, and it should not inappropriately delay endoscopy. Again, radiological workup is not mandatory and should not delay urgent endoscopic removal of a pointed or sharp foreign body. When absolutely necessary and only when possibly performed in a timely manner, neck, chest, or abdominal radiographs are often sufficient to assess the presence, number, size, shape, and location of radiopaque foreign bodies. CT scan is sometimes needed to determine if obstruction or perforation is present, or to assess the presence and number of non-radiopaque objects. X-ray contrast study should not be performed. First, because they may delay endoscopic treatment. Second, because those viscous agents may interfere with endoscopic visualization. Third, because hypertonic solutions can cause acute pulmonary edema when aspirated, and barium is contraindicated when a perforation is suspected. While awaiting endoscopy, pharmacological treatment can be attempted. However, these treatments should not delay any urgent or semi-urgent endoscopy. There is some controversy on the efficacy of glucagon alone or in combination with benzodiazepine or nitroglycerin to ease the passage of the food bolus into the stomach. No significant efficacy of buscopan has been demonstrated yet. Overall, ASGE guidelines support the idea that glucagon is a safe and acceptable option as long as it does not delay endoscopy over a reasonable time. Do immediately proceed to endoscopic removal of burden batteries. Ingestion of cylindrical battery is rare and usually non-severe. On the other hand, the widespread use of large and high-voltage burden batteries is associated with an increased number of ingestions, which can be life-threatening. Most of these cases are seen in children under 4 years. Burden batteries impacted in the esophagus can cause electrical burns, caustic burns, and necrosis, and should therefore be extracted urgently. Retrieval nets are most useful in this indication. Here you can see the aftermath of an accidental ingestion and impaction of a burden battery in the lower esophagus in a young adult patient. The patient had chest pain, but no hypersialuria, crepitus, or fever. She was immediately transferred in the endoscopy suite at 2 hours post-ingestion. The battery was extracted from the lower third part of the esophagus with a retrieval net. 2 large vesicular separations with black necrotic haze and a blue halo lithium crystals were found. The lithium crystals were flushed and aspirated to prevent further caustic injury. The CT scan showed no sign of perforation. The nasogastric tube was placed, followed by 4 weeks of uninterrupted nutrition. Endoscopic evaluation at week 4 showed complete mucosal healing and no stenosis. Oral intake was then resumed and follow-up was uneventful. First conclusions. Do make varied equipment available to face varied foreign body ingestions. Do secure data collection when on call. Do anticipate general anesthesia with endotracheal intubation for airway protection, for upper GI foreign body extraction. Do immediately proceed to endoscopic removal of sharp or pointed objects. Do not allow lower the endoscopic removal of a rectal foreign body. Do not delay endoscopic removal of football sanctions. Although 12.
Dr. Patha, I think you can stop it for a minute. You can stop and restart the video for a minute. There is some difficulty with the audio. Yeah, there seems to be some problem with the audio of this recording. We'll just try to fix that in a minute.
Do anticipate general anesthesia with endotracheal intubation for airway protection, for upper GI foreign body extraction. Do immediately proceed to endoscopic removal of sharp or pointed objects. Do not plan
Is it better
lower GI
now?
endoscopy for
Yeah, yeah.
removal of a rectal foreign body. Do not delay endoscopic removal of footballus impactions over 12 to 24 hours. Do immediately proceed to endoscopic removal of button batteries. Another don't. Don't attempt endoscopic extraction of body pack. Body packing consists of illicit drugs packed within latex condoms or balloons, then swallowed or inserted in the rectum or the vagina. Any endoscopic attempt to remove these foreign bodies is contraindicated because the outcome can be fatal in case of a rupture or leakage of the content. Surgery should be performed instead. Sometimes you must do don'ts. Here you can see the case of a young adult patient admitted for chest pain and hypersialuria 24 hours after ingestion of dozens of narcotic packs. The patient had no sign of shock or perforation. A CT scan showed multiple drug packs along the gastrointestinal tract. Numerous packs were impacted in the esophagus. Despite being contraindicated in theory, due to the risk of rupture, endoscopic extraction was decided as surgical management of this very dilated esophagus was felt at an even higher risk of fistula. The patient was admitted in the operating room at 26 hours of ingestion. The surgical team was standing by in case of a rupture. A rapid sequence intubation was performed given the aspiration risk. All esophageal packs were extracted with a retrieval net and none showed any sign of rupture. The patient was admitted in the intensive care unit for surveillance. He received laxatives to accelerate the passing of the other packs. Follow-up was uneventful. As final conclusions, I would like to add that you should not attempt endoscopic extraction of body packs, but you should build your own local experience and learn when to do don'ts and when not to do those. Thank you very much for your attention.
So that was a really interesting and a very comprehensive talk by Dr. Xavier Dray. We already have a couple of queries in the chat box, but we'll take them in the Q&A session. For now, I would like to invite our second speaker, who's Dr. S Easwaramoorthy. Dr. Easwaramoorthy is not only an accomplished surgeon and endoscopist, but he is also a passionate teacher of endoscopy and has trained more than 1,000 surgeons in the art of endoscopy through the various courses which he conducts across the country. Dr. Easwaramoorthy is also the section editor for the book titled Comprehensive Textbook of Laparoscopy, which is published by IAGS, and is also the editor of Endoscopic section of Journal of Minimal Access Surgery. He has authored 3 very popular books in surgery, including the textbook named The Art and Science of Endoscopy. Sir is the immediate past president of the Tamil Nadu and Pondicherry chapter of Association of Surgeons of India and is the president-elect of Indian Association of Gastrointestinal Endoscopic Surgeons. It's my pleasure to invite Dr. Easwaramoorthy, sir. I would request you to start your talk now.
Thank you, Bhavnit, for your kind words. I hope my audio, my presentations are clear to you from
Yes,
your
sir.
end.
Yes, sir.
Thank you very much. Thank you, Partha. Thank you, Bhavnit. Thank you, TUGS Endoscopy. I bring greetings from IAGS, ASI Tamil Nadu chapter, and also the turmeric capital of the world, Erode. Our place is known for the spice turmeric and also textility. And this is a very important topic close to my heart because we, under the auspice of IAGS and also in the various form, we feel the art and science of endoscopy should be taught from the postgraduate onwards for all the surgeons. because the potential of endotherapy is so immense. Sooner or later, whether we like it or not, more than 60% of our surgical disorders are going to be handled by the flexible endoscopy platform. With that foresight, I think it is our moral obligation as a trainer to impart this important knowledge. Upper GI bleeding being a common emergency, let me just say few from the surgeon's perspective and many aspects from the endoscopic perspective. Let us go on managing from the upper GI bleeding with this following learning objective. I'm just going to have an hypothetical 4 different cases wherein a patient presenting either with hematemesis or melena, and there why I do an endoscopy, when I do an endoscopy, and where I can accomplish the treatment by a therapeutic endoscopy. And am I going to manage the patient as a whole, or do I need to have a team concept trying to involve others like a radiologist in particular, where when I fail or I have nowhere to go? And I have to base all my things apart from my personal clinical experience of the last 3 decades with what the literature says as of now, the evidence-based, experience-based, the learning for the next 25 minutes or so. Let's move on. Because if I'm going to see a patient tomorrow in my emergency or ER, presenting with either of these symptoms, I'm going to go like a postgraduate in a 5-step process. Have a quick history and examination. Make a working clinical diagnosis. Resuscitation should go along with your investigation. And then you need to decide about how risky to do a procedure. That is a risk assessment of the patient, whether the patient has to go straight to the ICU or straight to OR, or can you just wait and investigate in the, inpatient in an ordinary ward. So you need to make a calculated thing depending upon the risk assessment associated with the patient, age group and comorbidity. Fourth, of course, is the area where we are going to dwell deeper. That is when, where, and how we do an endoscopy. And we are going to do an endotherapy. What are the tips and tricks? Let's go on. See, for example, if you're going to see as a beginner, when you see a patient, you need to get a comprehensive history, especially so their comorbidity. Very, very important thing which determines the patient's outcome is not only the cause of the bleeding, what is accompanying them. A patient with ischemic heart disease, COPD, not only doing an endoscopic procedure itself may be a daunting task, and also 30-day mortality is significantly slightly high. We say rule of thumb, about 5 to 10%, the mortality is accepted in high-risk people. But now with a good resuscitation, good anesthetic and intensive team, we have brought down the mortality to an acceptable, very low level. Drug history is very, very important. Most of them may be already on drugs I have enumerated here. And alcohol, patient might have had alcohol just a few hours before. So these are all the things challenging for you. Get the history comprehensively. Then examine them head to foot, especially look at the blood pressure, see how bad the anemia, and especially in our country in particular, thanks to alcohol available so widely, rampantly. So we have this variceal bleeding as a very important, it's a situation beginning as an emergency. I would say probably 40% of my caseload is nearly variceal bleeding. And variceal bleeding, non-variceal bleeding, they are oranges and apple. You can't compare because variceal bleeding by nature, if you compare, they are like a downpour. They bleed a large amount in a very short time. Whereas it is a drizzle as far as this other non-variceal. Usually they start small herald bleed, but if you leave it, it might lead into like a volcano erupting. It may be a massive bleed later, like a posterior duodenal ulcer. So you need to be very careful, make an working diagnosis. One thing I request the postgraduates or anybody is examine the patient for liver signs like a liver sulfide, especially splenomegaly. A patient with a splenomegaly with other signs like a palmar erythema and alcoholic, you always be sure it is going to be portal hypertension unless otherwise it is likely to be a case of esophageal varices. So you have to get ready with all the gears necessary. Of course, you need to look rectal examination to see whether it is a melena or a hematochezia. Coming to the next stage, how aggressive your resuscitation. And the word I use is a conservative resuscitation. What do you mean by conservative resuscitation? I won't be in a rush to bring the BP back to normal. if you bring the BP very high, he is going to rebleed again. So I'll be putting the Venflon or the white bore needle, but I would be very restrictive. The amount of the volume be transfused, be it a blood or the crystalloids. I try to keep the hemoglobin hovering around 8 grams. I won't try to make it normal, because until you get the source control, don't be in a hurry to push blood, and rebleed is quite possible. The second risk in most of these people massively bleeding is aspiration. Never hesitate to intubate. I have seen people who are massively bleeding, unstable, very severe bleeding, intubate, you have a control, because days are gone where I use sense-taken Blackmore tube. If you ask me now itself, I'll tell you, sense-taken Blackmore tube is now in the fridge. It is more like a museum piece to me. Thanks to the pharmacotherapy of like a terlipressin, and also an efficient management with the plasma, then we get the patient onto this table for endotherapy fairly soon. So we don't rely on this sense-taken Blackmore tube, which if it is not used sensibly, it can be more lethal than doing any good to the patient. That's my caution button. Coming to the investigation, of course, you need to do all the battery of investigation, especially in a variceal bleeding. I like to see the patient's albumin level, bilirubin level, and prothrombin time. An albumin level less than 3, bilirubin level more than 3, not a good news for a patient. A clot showing a prolonged prothrombin time warrants that we need to address this issue first. I don't want to do an endoscopy in a patient with the prothrombin time more than 1.5. I mean INR more than 1.5 for that matter. And of course, we need to get the viral markers also ready. Universal precaution when you are doing any procedure for that matter. And the X-ray chest ECG in our algorithm, ultrasound bedside is ideal to know about the liver, splenomegaly, portal vein, or any other exciting or interesting causes you can find out. Coming to the risk assessment, that our step 3 before our endoscopy venture is you see which patient is going to do poorly. An elderly person, patient with a comorbidity, or patient with a shock on admission. These are the 3 things. Of course, patient requiring a large volume of blood transfusion, more than 4 units in my opinion. There are various risk scores are available. In an institution, you can adapt either Rockall's risk assessment score, which is commonly used, or a Glasgow-Blatchford score also. But usually, a clinical predictor is a good enough one. So I would follow age, elderly man with a comorbidity means usually they have a poor outcome. You have the best chance, is your first chance of endotherapy. So you go for this jugular, like what I call, you go for a combination therapy or surgery, whatever. Don't sit on them. If they rebleed, then outcome is not that good. Coming to the main area where I'm going to dwell a little more deeply is how, as an endoscopist, I'm going to perform. Thanks to the era of video endoscopy, you have right with you a high definition endoscopy. So you'll be able to find out the cause, even though the chart says a non-variceal bleeding is 80%. In our conditions, the variceal bleeding is now 40% of our incidences are there. And occasionally, rare causes. Even yesterday, we had a polyp presenting as a bleed. Last week, we had a leiomyoma presenting as a bleed. So there are some unusual lesions. You'll be coming and trying to tell you that you are never master. So it is like every other day, you have a hernia, which will be challenging to you. Every other day, we have a GA bleeding, where the source is very difficult. Source control is even more difficult. Coming to the steps of approach, what do you need? An endoscopy, I'll do not in a hurry. I never do endoscopy nowadays an act of desperation. I optimize the patient. I have the pharmacotherapy. If it is a variceal bleeding for that matter, I'll put the patient on the terlipressin. I will not think about Ryle's tube, because that process itself sometimes initiate bleeding. So I won't be in a hurry to put a Ryle's tube. That is a controversial, we'll discuss later. The third thing probably I'll do is I'll get the clotting screen done so that I'll correct it in the meantime. And endoscopy within 6 to 12 hours in our department. But most of the institutions, they do it by the next day. That is within 24 hours you need to do. The statistic says when you do an endoscopy within 6 to 12 hours, there is a 90% chance you'll be able to identify the source of the bleeding. Still, there is a 10% you will miss it. Why you miss it? There are two reasons. One, the lesion is in a blind spot. You miss it, especially if you are a beginner, like a posterior wall of duodenum or a fundus of the stomach where there is a clot is preventing you to have a good view. Second thing, why you miss it? A mysterious lesion. What do you mean by mysterious lesion? The lesion, which could be a different thing, which you see it once in a year, like it could be a case of a hemobilia, where there is a bleeding is only from the ampulla, or a hemosuccus pancreaticus, or it could be a ioto enteric fistula. All those unusual causes may be there, or intermittent bleeder, like a Delophoid lesion may be there. So there are some, in other words, you never get a diagnosis for the first endoscopy. Sometimes as a more experienced fellow, you have to come back after a few hours with expertise in a relaxed, good environment for what I call a second look endoscopy. So don't underestimate. For example, a patient is referred to me, endoscopy done, few hours ago, we didn't find a lesion. I won't be happy. I will do endoscopy the patient before I think about colonoscopy, which is very sensible option in those cases. That's a caution I wanted to tell all the youngsters. Coming to the what type of endoscopy you need. Do you really need a therapeutic endoscopy? I don't think it is really required. Thanks to the good irrigation device I have, which can be adapted to the side channel or access channel. With the foot pedal, I can flush the stomach so well, so I'll be able to get all the clot and blood in a matter of time. In a double channel therapeutic endoscopy is a luxury. It's not absolutely necessary. I've been using only a conventional endoscopy, satisfactory. I never regretted of not having a therapeutic endoscopy. Let me say that way. But a better irrigation device is really a good one, and we know the importance. Of course, we need to have all the accessories ready. Back on when we do the endoscopy, behind me will be a big tray with all these accessories available. I have a hemostasis tray. It'll have everything, like varices tray, and we'll have plan A, plan B. We have a team concept. Before I do, I'll tell them, I'm going to use this endoscopy. If I see this lesion, I'll do. If not, what I need. They should not go after the accessories. You need to keep them everything ready before you venture out. That's the other thing I wanted to tell you. Sometimes I'm sure some of your colleagues will be wheeling the whole trolley to the ICU setup, where you need to do the procedure on the bedside of the patient. You have to get all the equipments there and ready to do the procedure. I'm sure Mayo Clinic, they have a very good unit where the hemostasis is done at the ICU setup. So if you have a good setup, get all the equipments as necessary. For example, if the banding fails, do you have the glue? If you have a glue, do you have a spare ampoule? Either you need to go and work as a clinician. Very, very important is out of hours, like that last interesting chapter we had about the foreign body. Everything is fine unless you have a good assistant. It's going to fail. So if a patient comes with the coin in the esophagus at 2 a.m., I rather wait for my assistant to come at 8 a.m. and do it rather than trying to do at odd hours. So try not to do anything odd hours unless it is a really urgent one, like a button battery. It is just a little extension of the talk. What I'm trying to tell is a team is equally important. The success depends upon your technique, the right tool, but the right team. Keep that in mind. Coming to the management as it is, let's imagine you have a case of esophageal varices. It can be just esophageal varices alone. Some people may have in addition of fundal varices or severe congestive gastropathy, all because of the portal hypertension. You need to see if they are pre-hepatic causes. Usually they have a baseline liver functions are good. They do well. Whereas if it is a hepatic or some of the post-hepatic causes, they usually have a baseline liver functions poor, like a low albumin, high bilirubin, ascites. They don't do very well. So you should be very, very careful. So that's a little caution I wanted to tell you. Coming to the treatment, just to give a quick look, I already told you, this is only to tell how a sensitive and Blackmore tube as used to be applied, distending the gastric balloon, maintaining a traction, hoping it will stop the bleeding from the fundal varices. If it continues to bleed, then if you think, then this esophageal balloon can be also inflated with a transducer. Then you can maintain the aspiration. But this is a very cumbersome procedure. In my humble opinion, I don't use it. I don't rely on it. I stop using it. Let us put it that way. So we spend more time on the other things. Like I keep all the variceal bleeding in our HTU and ICU. Consider full frozen plasma. In some people with a very low albumin also may be useful. Fresh blood, these are the things. Avoid saline. That is a very, very important message. Ascites gets worse if you give a lot of saline for this patient. Terlipressin, in my opinion, is a wonder drug. Very less side effects. 1 to 2 milligram, 6 hourly we can give. And in my opinion, this is better than the somatostatin octreotide, because somatostatin in infusion, octreotide also as an infusion may be okay for a post-banding for a prophylaxis, as it is to stop the bleeding, as it is to bring down the portal pressure. Terlipressin is very effective. It is my clinical experience. And maybe some subjective element is there, but I want the opinion from our co-moderators. And always consider these people are notorious to go into hepatic encephalopathy, go for antibiotics, encephalopathy prophylaxis, and start deciding which endotherapy is required. If it is a varices, big varices, banding. If it is a gastric varices, glue. G for G, B for B. That is a very simple mnemonic experiment. Coming to the, as far as the banding is concerned, will you band all the esophageal varices? If you asked me, there is a classification worth recollecting from 1 to 4. Grade 1 is a varices so small, when you go and inspect the esophagus, insufflate it, it will disappear in front of your very eye. The beginners, sometimes they overlook it. That's why we call it as classically as a missing varices. Whereas if you go into the next one, that is varices are so big, and even taking the endoscopy in an insufflated esophagus may be very challenging, and is kissing varices with no space. So missing is grade 1. So big kissing type of big varices are grade 4. And between them, you have different widths, more than 5 millimeter, less than 5 millimeter. They are grade 2 and grade 3. In other words, this particular page where I'm saying grade 3 here, grade 4, these are ideal case for banding. A primary banding is a typical thing, which as a surgeon, you can see one, do one, even you can teach one. Because procedure-related morbidity is less, easy to master, provided you know all the tricks and tips. Coming to these smaller varices, sometimes they may be innocent bystander. The actual bleeder may be down below, like a fundal varices or some other causes, to be frank. But if they do bleed, especially 1 or 2 residual varices because of high portal pressure, sometimes you can give a sclerotherapy. Either a glue is preferable, or you can use various sclero agents are available. But take it from me, sclerotherapy is now slowly coming off because of good banding. And we do very rarely the sclerotherapy, which used to be the bread and butter endotherapy in those days, like using a sodium tetradisyl sulfate, ethanolamine oleate, polydocanol, all those drugs we do use, but how often use? Very seldom we use, especially for a residual varices, very, very rarely. Coming to the two things, what I want everybody, especially the juniors, to understand, it is not the length of the varices which is important. It is the size, the width of the varices, and what is on the surface of the varices, which are going to be the predictors, whether this particular varices is a cause of the bleeding or is going to be the cause of the bleeding. That is called risk markers. One, of course, is a cherry red spot and also the red whale sign. What do they mean? They mean not submucosal, they are intramucosal varices, because we all know it is a stratified squamous epithelium. Within the layers of the squamous epithelium, it is intramucosally, there are venules are dilated. Just with a little coughing, a little increase in the portal pressure, they can bleed like torrentially. That's why I say it's a downpour. They can just bleed about 500 ml a matter of few minutes. So these are the predictors. If you see that, you need to band those areas carefully. This lady, she presented with a massive hematemesis. Then after optimizing her, we went in, and then what we did, a diagnostic endoscopy showed a grade 3 varices. So what you need to do is a banding assembly, which is basically what you need to do is, in addition to your big wheel, small wheel, there is a red wheel, you attach it, or different types of wheels are available in the access channel, through which you pass this full catheter, then reverse load this barrel, which is having a preloaded 6 rubber bands. And then once you have a suction applied, this suction will suck the varices. Then you, with a handle, with a forward movement or a clockwise movement, you'll be able to release the band, and all these varices will become like a grapes, like this. So it is just to show, this is the way you go and suck it. The suction is the basis of success in this procedure. Sometimes if you have a 6 bands in this barrel, the first band, I'll release it in my finger glove to check the whole thing is working, what I call a dry run. You do the dry run, because soon people doing it very well know, when you put all the barrels, the view becomes like a tunnel vision. So vision is poor, especially after putting the barrel. So I put 1 or 2 waste itself. If I especially need only 2 or 3 bands, I'll waste first 1 or 2 bands to test run, and also to get the visibility better. Then good suction, release it gradually, then deploy it, but don't deploy them all in the same level. Deploy 1 centimeter in a spiral fashion. Start from the OG junction. So these are all some fundamental basic things you need to understand. Like here, okay? So this is before, this is after. What happened to the bands? Will it remain? Even the patients ask, sometimes GPs ask, they have to know after 48 hours, the bands slough off. Okay, so this is just a video clip we have taken after 3 days after band. This is what the look of the bands. You can see that area becomes necrosed, then sometimes slough off. 5 days, 6 days after banding, if you have a patient with hematemesis, usually it is because of the band-induced ulceration. And that sometimes may be notorious. Keep them nil orally, give them terlipressin. If necessary, you may have to go back and sometimes consider giving glue injection underneath. So this is a very tricky situation. So you have to be very careful. If you band all at the same level, something like this, you can get what is something like a Schottky's ring, something like a circumferential stricture. So you try not to put a band all at the same place. So these are all a few problems, few recommendations I like to give. When you do a next sitting, when you do these patients, I usually bring these patients after 3 to 4 weeks time for a surveillance endoscopy for a second sitting if necessary. So that's about it. What else we have? We have another patient here. This gentleman, he presented with a torrential melena, and when we did an endoscopy, he had a tiny little esophageal varices. But when we did a retroflexion, we saw what looked like a hanging, bunches of grapes. The beginners may not recognize it as even a varices. I'll tell you. But there are various ways. Now we have the endo ultrasound, various avenues. But still, as a surgeon, we know the way, the color, and the yielding nature, everything will tell it is nothing but a esophageal, the fundal varices. The main thing is to reach it, to address it is very challenging. Fundal varices is not for a light-hearted people. It is not a level 1 training. It's a level 2 training. So because giving the injection itself is a daunting task. If you get a bleed during bleeding, you need to have a plan B. That is even more challenging. So in my opinion, if you are not well versed with this procedure in a large number, you please get more expertise on your side. So all these things you need, of course, glue, syringe, distilled water is very, very important. And this is the way you have to address in a J manual. So you have to go in like this, then bring the needle out, viscous fluid. So you need to have a 21 gauge needle, not a 23 gauge needle. And then trajectory is important depending upon the scope you are using. Then you get the right trajectory. And if there are better ways of addressing now, thanks to the endo ultrasound, but this is the simplest way. You can go with a wide bore needle, bullseye, you go right into the varices, you inject 1 ml, then followed by 1.5 ml of distilled water, which will drive all the glue from the plastic into it. Then withdraw the needle, keep the hub of this plastic for a minute there, so that the hole is sealed with this plastic, so that there won't be undue bleeding. So there are little tricks, but one thing you should be watchful. Banding depends upon suction. The suction is an enemy here. If you suck, all the extravascular fluid goes into the channel, which may cause a blockage of your channel. There is a little warning I want to give you. Keep always a bottle of, or at least some amount of acetone as a fluid to flush the channel and also clean the lens. And also it is advisable you wear what we call a goggle if you are like me. Otherwise, your blue eye become a glue eye sometime. So you have to be very, very careful. And the fundal varices, are they all easy if you ask me? There are various classifications. Here, this is a esophageal varices continuing as a fundal varices, gastroesophageal varices, GOV1. This is along the greater curvature, GOV2. This is isolated gastric varices, which is having a more propensity for a severe bleeding. This is also isolated gastric varices, ectopic varices, IGV2. So here is a GOV2 we are addressing. So you need a good staff nurse, spare ampules, because if you inject too fast, theoretically you can cause embolization. Okay, you should be very careful. Channel block is a problem, and rebleed can happen. You need to have a spare ampule, spare catheter. Everything is very, very important. So you have to, so don't take the glue injection lightly. Now, thanks to the endo ultrasound guided injection of these coils are available. I'm sure I like to learn. I don't do it personally, but I think that is now slowly establishing itself as a standard of care as far as endotherapy of the fundal varices are concerned. So to summarize the variceal approach, as I said, big esophageal varices banding, small esophageal varices later stage sclerotherapy, gastric varices glue. We see them monthly until everything is eradicated. If it's second time I fail with the banding, I send them to my radiologist to consider for a TIPS procedure, and very rare nowadays to do a shunt procedure. I don't think I have referred anybody for a shunt in the last decade or so. Sclerotherapy, for example, here, just to tell you the principles, we give, these are all the classical grade 2 varices with the telltale red veil signs. We either inject into the vein, intravaricial, or along the vein, paravaricial, or combination of these two, what we call a sandwich technique. There are various things I explained, but main thing is you have to tangentially you to enter, because unless you are very careful, you can cause the needle going beyond the esophagus. It can even cause mediastinitis, ulceration, pleural effusion, various sorts of things. So you should be very, very careful not to get into this trouble. So once you have done a pan diagnostic endoscopy, as we normally do here in this insert, you come back, take the needle, 23 gauge, and get the trajectory, tangential trajectory. Being an Olymposcope, 7 o'clock it comes, and bring the varices at the right spot. You give the command sequence to your staff nurse. So needle out means she gets the needle out. Needle out only 3 millimeter means she gets the right size of the needle out. Then inject a quantum, usually about 0.5 to 5 ml, needle back in, and slowly you take off. The procedure related bleeding to me is slightly more than the banding. Personally, this is only reserved for a residual small grade 1 varices. It is just to show you how we inject intravarically, right above the OG junction. Sodium tetradecyl sulfate, ethanomen oleate, these are the two common chemical material we normally use in our department. Prophylactic antibiotic is very, very important in these procedures. As I said, TIPS procedure is very, very useful rescue procedure if the patient continues to bleed, especially with a high portal pressure. But its patency is now getting improved. We have a very good radiologist nearby, so I always get his opinion for the suitability of a particular case before we refer. Next, of course, is the shunt procedure, be it a splenorenal shunt, or those days we used to do even a Segura procedure. I did it about 25 years ago. So those are very exciting procedures, but now with a very aggressive endotherapy, we seldom have a situation where we have to do all this procedure. What about a few minutes on non-variceal causes, if you ask me? Malarious is a common problem. An alcoholic, a bout of vomiting, followed by a large bout of bleeding. Usually you see the lesion just above or below the OG junction. Erosive gastritis, either drug-induced or alcoholic, or H. pylori-induced severe duodenal ulcer, all can be present. Yes, you need to resuscitate them as we normally do. Do an endoscopy within 24 hours. But very important thing we now adapting is a high dose intravenous PPI, usually as an infusion, like 8 milligram per hour, or as a bolus like 80 milligram IV 8 hourly. And if you do H. pylori and find to be positive, H. pylori eradication is also useful. What is doubtful is these two, IV tranexamic acid, Ryle's tube insertion. I am still keep on telling you, we stopped inserting Ryle's tube in all GI bleeding. That is my personal way of managing these cases. But one thing everybody should understand, all ulcer bleed, we need to adapt forest grade of grading before we doing anything, because it's a very good grading to predict which one is going to bleed. Because if you see a bleeder, actual bleeder, potential bleeder, non-bleeder, 1, 2, and 3. Actual bleeder, here sometimes you have a vessel which is spurting like an artery or oozing like a small capillary ooze. So spurter or oozer, active bleeder, anybody, if they are seeing, they are not going to come out without doing anything. So endotherapy is very important in this situation. Whereas here is a million-dollar question. Which one of these will require endotherapy? That is a potential bleeder. It was bleeding yesterday. It might bleed tomorrow. That is what we call a potential bleeder. It could be a non-bleeding visible vessel or adherent clot. Even after irrigation, it is not going to go, or some pigmentations. Especially the 2A, or in my mind, even 2B, you need to consider giving endotherapy. And easy to do endotherapy here because it is not bleeding. You can always give a 4-quadrant dilute adrenaline, then contemplate about other additional mechanical devices. Whereas one for sure, if it is a non-bleeder, is this one, clean-based ulcer. You send them to the ward or even outpatient department treatment. So that's all about so forest classification is a very good classification we can adapt to predict the bleeding tendency. There are occasions where we have seen a Gave syndrome or Dulophi lesion. See, here is a one interesting case where we have seen, let me just show the video later, and leiomyoma also. So these are all the risk factors for recurrent bleeding. As I said already, the elderly people, shock on admission, low hemoglobin, requiring a large quantum of blood, or if they have endoscopic features, this and or Doppler positive lesions, you need to consider endotherapy. Also, there are occasions, sometimes even as a surgeon, I need to take them to OT. These are all the modalities I have. Still, as a peripheral surgeon, I still feel a good usage of this, a cheap, effective way. But now I am do it as it is as a solo. I usually combine it with either thermal method, occasionally with the hemoclips. So this injection of dilute adrenaline do help. Like this patient came recently after having taken diclofenac for his lumbago, presenting with melena. So when we did, this is what we saw, a lesion, as you can see. So as you can see, this is the anterior wall of the body of the stomach. I have the 23 gauge needle ready, dilute adrenaline 1 in 10,000. This is a forest 1B. So I am giving a 4-quadrant injection. Like the pictorially I'm demonstrating here. Don't go into the bullseye. Do 4-quadrant, trying to increase the tissue pressure and then vasospasm. Then you can go right in the middle. If necessary, you can clip it or give a contact coagulation, for example, or coaptive coagulation. Gold probe we have. I found that is also equally good, a bipolar with a gold probe. So these are the commonly used modalities. Sometimes, especially when you have a spurter or a polyectomy site bleeding or some other unusual causes, it may be possible that you can take a hemoclip. You can either torque the scope or it is a rotatable clip. You will be able to put 1, 2, or even more clips to the area of bleeding. It's very, very effective. Having started using this hemoclip, now the need for even a surgery, like those days are gone where you need to go and do underrunning the ulcer, is more like a history now. Because this situation, but other interesting thing we have used this a hemospray. We don't have a hemospray as it is. We have the collagen as a spray in a pressurized canister available. And if you have a diffuse area, and there you can spray the whole area and it contains the bleeding. And at least it gives you a breathing space. You can come the next day, have a second look. By then, either the bleeding has completely settled or you can have the controlled environment. You can decide what to do. So these are all the new gadgets on the market. You can consider all of those things, but never forget your team. If you fail, the radiologist always there. If an endoscopist, if it's not possible, you go to the surgeon. If surgeon thinks it is better job with the patients with the comorbidities done by a radiologist, interventional radiology, transarterial embolization is possible. We have seen 2 or 3 cases of duodenal ulcer. My interventional radiologist is able to embolize the vessel, able to effectively do the procedure. It is a wonderful procedure. You need to get the timing. Don't, in other words, it should not be an act of desperation. Early referral is very, very important. Occasionally, a large duodenal ulcer or a very high gastric ulcer with a large bleeding, you may have to submit them for surgery. Like here, this is a older picture. You can do a duodenotomy and see a large duodenal ulcer. Usually the gastroduodenal artery sometimes bleeds torrentially. In those cases, you may have to underrun both above, below, sometimes also the transverse pancreatic artery also you may have to ligate. So that's a way you can do. Then you can control duodenotomy. Will you do along with that vagotomy, if you ask me? If it's a bleeding cause, usually we do a vagotomy, truncal vagotomy, if you have done this procedure. So this is just to make my presentation comprehensive, the role of surgeon, role of endoscopist, role of interventional radiologist. These types of very extensive surgeries are very seldom required nowadays, like doing an antrectomy, Billroth 1, 2, Roux Y, which are now reserved more for other neoplastic conditions. But these are all the once in a while we'll test your nerves. Here is a case where the patient was bleeding intermittently. And when we went once, when the PP is back to normal, we find small area, normal looking stomach spurting like this. This is apparently what was called as a Dielophile lesion. A Dielophile lesion is a lesion which is a bleeding in the proximal half of the stomach, usually along the greater curvature or sometimes even lesser curvature, usually arteriolar bleeding like this. And we managed to contain initially with the adrenaline, then we applied a hemoclip. Long ago, I had the similar case. I was not sure what we were dealing. We had to go in after giving a methylene injection there. I had to do a little mini gastrotomy and do a procedure under. In other words, depending upon your situation, you do. Very important thing is hemostasis. Whether you are able to achieve endoscopically, surgically, safety of the patient is of prime importance. That is what I'm trying to drive at. And these are all rare causes like aortoenteric fistula. This year, we do have a lot of cases with aortic aneurysm being operated before, so they can have this presentation. Whenever you have unusual amount of bleeding coming from the third part of the duodenum beyond the second part, especially if you do a CT, you'll be able to contrast CT, you'll be identify this, and this is requires a vascular surgeon's immediate intake because it associated with a very high mortality. The final thing is, of course, understanding these are all the mysterious lesions. Once in a while, you'll come across like a hemobilia, presenting with the bleeding from the biliary system, presenting following, for example, liver trauma or ERCP, or bleeding from pancreas because of previous endoscopic ultrasound-guided biopsy or a pseudocyst or a pancreatic tumor. So as I said, it is a multidisciplinary approach. Me, never win a battle. I have to have backing up my medical gastroenterologist, intensivist, interventional radiologist with the patient safety at the center. So I have so many of this referral, I think is worthwhile. ESG guideline, UK guideline, ASG guideline, more recent ones are this one UK guideline on the variceal, non-variceal bleeding, worth remembering. People interested to read my book on a comprehensive way of tips and tricks of all this variceal, you can go for my endoscopy book, and colonoscopy about the polypectomy related complications also be mentioned. I hope you got some clue about managing these types of patients. I'm waiting for your feedback. As I said, early endoscopy by an expert is much better because a beginner may lose the sight of the bleeding because of the missing lesion or a mysterious lesion in 20% of the time. Endoscopic hemostasis in my hand is effective in 80 to 90% of the situations. Multidisciplinary approach is the order of the day. Thank you.
Thank you, Dr. Easwaramoorthy. That was indeed a very, very comprehensive, interesting, and informative talk. I'm sure everybody has gained so much from listening to this talk of yours. And we'll open the session now for the Q&A and panel discussion. And there are a few questions which I would like to put forward to the panelists. What do you suggest for a Forest 2B lesion? That's question number 1. Dr. Easwaramoorthy, sir, would you like to take that?
As I said, Forest 2 lesion, depending upon the cause of the bleeding, if it is going to be an erosive bleeding or a small ulcer, still dilute adrenaline is good enough. And then you put the patient on H. pylori eradication if the H. pylori test is positive. Most of them with the high PPI, this triple combination, invariably, I don't think you need to do a combination therapy. These people, even injection, they say it's low because only 1A is accepted as a definite indication. Sorry, 2A. 2B is a controversial. There, I am not going to sleep with that lesion. I would rather give a dilute adrenaline all around if I'm able to do that. Is good enough. Or sometimes we do even a APC in those occasionally in some situations. But I don't go for a mechanical therapy. There is no need for any other additional combination therapy in those situations. I wait others' comments. Any of the moderators want to give any input, please?
Yes, sir. Dr. Arvind Khurana, sir, your comments?
Regarding 1A, 1B, I agree. One has to go for combination therapy. Start with injection of adrenaline, 1 in 10,000, 1.5 to 1 ml, maybe 2 ml per quadrant, and you can go up to 8 to 10 ml in that, followed by second therapy. Either you do a gold probe, you do a multiple retrocoagulation, or you do a hemoclipping. But normally I do hemoclipping in my patient. Regarding 2A, I again agree with the visual vessel, it is better to go for combination therapy. But for 2B, we still treat by injection therapy, but no need for any second mechanical therapy. I do agree with it.
Right. Thank you, sir. So another query is, any role of stents in the management of a Melry-Weiss tear?
Role of stents?
Any role of stents in Melry-Weiss?
No. There is no role of stenting in the patient with Melry-Weiss. In fact, 80 to 90% of these will stop on their own. You don't have to do any endotherapy also. Only when you see an active use, you can do some kind of endotherapy. Even at least just more than sufficient. But if required, one can do a hemoclipping. Only when you have severe retching leading to a perforation like Bohr-Haave syndrome in full thickness, then you may have to go for a stenting, but not for the bleed part.
Yes, and also probably they meant stenting for esophageal variceal bleeding, because nowadays it is something like a pulse pressure effect it is going to cause, because we are now not using a sense taken Blackmore tube. LR stent is one stent has been designed for this purpose, which can be deployed very easily. But I think, as I said, as a good endotherapist, it is a very expensive way of treating, but obviously it is still in the evolution. Not many people have an experience of using a stent for esophageal varices. I haven't used personally myself.
I have done 2 cases, but I found that basically they are not used as primary therapy. They are mainly used for field therapy. And they are also useful for patients who have developed post-EVL large ulcer, which are bleeding massively, where you can't see the bleeding. So there you apply this stent and leave it for 7 to 10 days. And then you take it out, and then maybe if required, you can do a further endotherapy. And I just want to tell one more thing. These patients, normally you have to use Dennis LR stent, but that is very expensive. Even if you use a normal, fully covered stent available from Cook, which has a large flare, that works equally well in these cases.
Right. So one thing what I would like to add is that we have to remember that Melry-Weiss is just a simple mucosal tear, whereas a Bierhaus is a full-fledged perforation of the esophagus. So the management varies. And another question which we have here is, will banding be feasible for a gastric fundal varices?
I think my opinion is, in the absence of glue, those days people tried everything. Even banding has been done. But now with the thick, gastric mucosa, when you do varices banding, you will be only causing more harm than good, in my opinion. So I would be very, very reluctant to attempt this one. So glue having established itself, I think you should not go any other treatment with a glue. Even a glue, if it is not injected in the proper place, it will do more harm. That's why nowadays ultrasound guided injection is nowadays advocated. That is a standard, slowly becoming a standard of care. So that's why I repeatedly telling, don't take it lightly, injection of the glue. The trajectory is very awkward trajectory, and you need to have all the gadgets available. You need to have the troubleshooting, everything back. I want Dr. Kurona's input.
I think the only role of bending in patient with gastric varices, that is OGV1, where you have just varices just at the G junction on the lesser curvature. There one can try the bend ligation, but not in OGV2 or isolated gastric varices. There is no role. In fact, as he told, it is a basically kind of massive bleed which you can't control. So one has to go for glue only.
And so there was a query about the role of coiling in. So it's probably the new kid on the block. So any inputs on that?
Though I do coiling. I do EUS, but I don't have any experience of doing EUS guided coil. But that is a very good technique in patient or large varices where you have place like big varices where even if you do a glue injection, it will not take care of all the varices. So there it is better to do coiling followed by glue injection. So that large gastric varices, the risk of bleed is very, very high after glue injection.
Right. So another query is any role of overstitch in GI bleed?
I think we should.
I don't think so.
Before overstitch, we should say about Ovesco clip. That is more important. Patient who have a bleed, who rebleed, especially from the peptic ulcer or any other lesion which is whether it one can do apply Ovesco clip. This is over the scope clips. They say if you have a bleeder which is more than 6 millimeter, normally up to 1 to 2 millimeter size vessel can be controlled with injection therapy and by normal hemoclips. But you have vessel which is more than 6 millimeter size, or if a patient has very large ulcer, either the stomach or which is fibrotic, where you cannot apply a normal clip, there one can use an Ovesco clip to control the bleeding.
Right, sir. Right. So I have a question for you, Dr. Easwaramoorthy, sir. So you mentioned about hemostasis tray, which should be right available the moment you are going in to scope a patient for GI bleed. So for everybody's benefit, I would like you to tell us what all accessories and equipments would you like to be present on that hemostasis tray of yours?
Yeah, the thing is, when you do it in your own room, there are two situations. Either the patient comes to your endoscopy room where everything is within the accessible limit, or sometimes you take the whole trolley to an ICU where you need to take them all. So you need to give them a clear idea. So you have to have a working diagnosis. Some people will have already had an endoscopy, how the diagnosis, like a varices, we have a plan A, but we don't know what it is. So you need to have all the things required both for varices, non-varices also. So I will ask some, first of all, banding apparatus, 2 sets. Then you need to have the injection sclerotherapy. If it is a glue, because the glue is not only for gastric varices, failed banding also. Sometimes what happens is, if actually the varices are bleeding, sometimes banding could be a very difficult thing. I just take the scope beyond the bleeding, that side of the shaft of the scope sometimes give you some amount of breathing space, like a tamponade to stop the bleeding. Then I'll get the irrigation device attached. As I come back, I'll be able to flush and see exactly where the bleeding. Then I'll get the glue. So you need to get the glue needle 21 gauge, and for the adrenaline 23 gauge ready, and a respective amount of ampoule of solution should be ready. I need to have 2 more additional staffs, because to mix everything, you need to have enough manpower. You can't manage with 1 assistant. So that is also equally important. As I said, good irrigation device is required. All those things, like a foreign body, for that example, you have all the tools. So you need, in foreign body, one of the benefits is you already most of the time know what foreign body you are going to see. If it is a coin, because already seen radiologically. So you can have a plan or even dry run. Here, it is like a guesswork, your expertise sometimes. And there are occasions where I take the scope out, ask them to settle down, because longer you leave the scope, more the patient rich, it makes things worse also. You need to take, decision whether the scope is going to be there doing good, or you rather take the scope and you help others to get all the things done is a very, very matter. That as a team man, as a captain of the ship, you need to make a decision according to the situation warrants.
Right. Thank you, sir.
I do agree. Speed is very important. Our GI bleed, it is speed. Teamwork and the speed is very, very important. If it takes a long time, you can make the condition worse. Patient become hypoxic, they have more bleed. So it has to be very fast work.
Right. So although you have already mentioned about post-EVL ulcer bleeds and the use of Denisella, so not everybody has access or availability of a Denisella there. So how would you manage or approach when you see a post-EVL ulcer bleed, sir? What would you do? What would be your go-to procedure for that?
You want me to?
Yes, sir. Yes, sir,
Yeah.
please.
There are two options available to us. One is that we can, again, if you want, you can use hemospray. It is not available in our country, so we can use a spray available from Sherry Pharma, Sherry company. Basically, it is available as hemo seal spray. So the same way, you just apply a spray over the bleeding area, and most of it will be able to temporarily control the bleeding. So that is one option. The other option is that you put the patient on vasoactive agents like terlipressin or octreotide to start these patients. Third option, which we don't use nowadays, is thin blackboard tube. That is one thing which can be used. Now I use good number of cases in the beginning of my career, but now we don't use any more. But that is one option which one can use to control bleed in post-EVL bleeds. And the fourth, a glue injection just below the area of bleeding.
Right. Thank you, sir.
We have seen a glue injection is very, very useful.
Yes,
personally, yeah.
Very useful.
Right, sir. So a couple of questions regarding the foreign body extraction, sir. How important is the over tube in foreign body extraction? Can you please highlight the importance of using a over tube for foreign body extraction? When to use? When would you like to use a over tube for that?
Basically, foreign body, I've done around 900 foreign body in the last 33 years. Over tube we use only when you have a very sharp foreign body, like a blade, pain, or a very big bone where you know it may cause tear on the mucosa. So there we use these over tubes. But otherwise, most of the cases you can do without over tube. Only for sharp foreign bodies one has to use the over tube.
I think the speaker has nicely demonstrated something like a frontal hood. That is a very good device. Most of the situation that is cheap, effective way. But the only thing is we need to teach our juniors how to insert it, reverse load it, put it in, so that when it comes through the cardia, how it unravels itself. So that's what we need to teach. Otherwise, it is replaced the need for overtube. Now I seldom use overtube for removing any foreign body. Unless you have to go several times to take. Sometimes there will be multiple foreign body. You have to go. That time overtube may be useful.
So quite often, sir, we have a case of a chicken bone or a fish bone which gets just impacted within the esophageal lumen. The ends of the bone just impinging into the esophageal walls. So how would you approach such a case, sir? You see an impacted sharp object within the esophageal lumen. What would be the best strategy for such a case?
Imaging is important in my opinion. Regarding the technique, I want Dr. Corona Professor, please give your insight.
Basically, in the patient with the foreign body, most of the fish bone, they are in the cricopharynx, they are not in the esophagus. They are rarely we see in the esophagus, they are usually in the crippen area, and you can really remove without any problem. And they were tiny. Coming to the chicken bones, when they get impacted, if they are lying transversely, it is better to give and do under anesthesia that will relax the esophagus and try to hold the one end of the. They will never penetrate the wall. They are usually fixed to the wall. The moment you give anesthesia, it becomes very lax. Try to hold the one end of the bone. Don't hold it from the middle. When you try to hold it, then you and pull back, it will not come out. So try to either pull the one end up or the other end down so that it becomes straighter or tangential. Then you can take it out without much problem.
Thank you, sir. That's a really important tip for everyone.
And
we always say foreign body removal, it needs the right tool, of course, your expertise, but common sense. Very often you want to think what is going to best there. So that all combination in the right time, it gives you the right result.
And one more thing, whenever you are removing a foreign body like this, when you hold, try to hold that foreign body like bone or anything from one end. Don't hold it from the middle. So once you're taking it out, then it gets stuck at various levels. So hold it at the one end then you can catch it with a snare and keep the snare away from the tip of the scope so that it is aligned in the long axis of the esophagus. Then it is easy to remove. That is important.
The typical example is a battery. For example, you have a 2A, 3A battery in the stomach. Sometimes they swallow. I don't know how they manage to swallow those batteries. When you put the snare, you should not put the snare right in the middle of the battery, something like that. You should put it, slowly bring it to the last 1 centimeter. Usually have a small groove there. Then it should be in a line of esophagus. So it is a little trick. Keep on moving it to the end, very end, then grip it. Then take it out, preferably with the hood, if you have, well and good. So, as I said, it needs all this common sense and dry run outside. It makes this very challenging, very exciting. Always I like foreign body removal more than any major surgery sometimes.
Very rewarding, very rewarding.
Very rewarding and satisfying, right, sir? Yes. Excellent tips, sir. Thank you so much. I'm sure everybody is just enjoying all these pearls of wisdom coming from your vast experience.
I think there are a couple of experienced audience are here. They expressed they wanted to share their thoughts. If you have time, Dr. Rubjyoti Datta from Guwahati, I think he has some exciting foreign body removal. Rubjyoti, are you still there with us? He may be able to give some input. And we have our IAGS Satish Mehta is also there. Yes. Anybody, just 1 or 2 tips. It is for benefit of everybody here. If you have a time before we close.
Yeah, definitely, sir. We have another 5 minutes to go.
Yes.
So,
Rubjyoti,
Dr. Rubjyoti or Dr. Satish Mehta, please welcome with your comments.
Can they unmute, or is it provision? I don't know whether.
I'll ask them to unmute themselves. So.
Because they are not able to do, otherwise they would have done it. Yeah, ask to. Yeah.
Okay, I guess they're not.
Yeah, Satish is coming.
Yeah, Dr. Satish is there. Welcome, sir.
Good evening.
Good evening,
Thank you very much. So it was a well-organized thing, and it was very informative, both on the foreign bodies as well as management of upper GI bleed. So it was a very informative session and good participation. And I hope in future also we'll have a very informative sessions and good discussions. So Easwaramoorthy, as usual, he has really good passion, and he's an asset to all of us. The way he
thank you.
He has written books, and he's always there to teach. So thanks the whole TUGS team, especially Dr. Bhalla, for taking pain to do this academic sessions regularly. Thank you very much, and IAG is always with you.
Thank you so much. Thank you so much. So I'll just take a moment to inform all the attendees here that it's an honor for us that TUGS endoscopy academic webinars are now endorsed by the IAGS, which is the Indian Association of Gastrointestinal Endoscopic Surgeons. And we hope to live up to the responsibility which has come our way, and it really inspires us to do better in the future also. So with that parting remarks, I will just ask Dr. Partha to share the links for our WhatsApp groups, and after that we'll just close this session. We are almost out of time. Partha, can you please share the feedback form and the?
Yeah, I have shared the link to the feedback form on the chats. And we also have a YouTube channel on which all the previous talks have been uploaded. This talk will also be uploaded on it soon. Thank you.
That's great. Thank you.
Thank you, Partha.
Thank you. Are we all relaxing Sunday? We hope to meet for a another session, interesting session with all of you.
Yes.
Nice interacting with you, all of you. Bye-bye now. Thank you.
Thank you so much. Thank you so much for your time and your participation. It's been a pleasure. Thank you so much, sir.
Thank you.